Doctors are supposed to practice evidence-based medicine, and they're increasingly called to join the genomic revolution. But their habit of treating patients by race lags far behind. Take the estimate of glomerular filtration rate, or GFR. Doctors routinely interpret GFR, this important indicator of kidney function, by race. As you can see in this lab test, the exact same creatinine level, the concentration in the blood of the patient, automatically produces a different GFR estimate depending on whether or not the patient is African American. Why? I've been told it's based on an assumption that African Americans have more muscle mass than people of other races. Well, doctors tell me they're using race as a shortcut. It's a crude but convenient proxy for more important factors like muscle mass, enzyme level, genetic traits they just don't have time to look for. But race is a bad proxy. In many cases, race adds no relevant information at all. It's just a distraction. But race also tends to overwhelm the clinical measures. Race can't substitute for these important clinical measures without sacrificing patient well-being. Doctors also tell me race is just one of many factors they take into account, but there are numerous medical tests, like the GFR, that use race categorically to treat Black, white, Asian patients differently just because of their race. Race medicine also leaves patients of color especially vulnerable to harmful biases and stereotypes. Black and Latino patients are twice as likely to receive no pain medication as whites for the same painful long bone fractures because of stereotypes that Black and brown people feel less pain, exaggerate their pain, and are predisposed to drug addiction. The Food and Drug Administration has even approved a race-specific medicine. It's a pill called Bidil to treat heart failure in self-identified African American patients. A cardiologist developed this drug without regard to race or genetics, but it became convenient for commercial reasons to market the drug to Black patients. In the end, the drug company's marketing scheme failed. For one thing, Black patients were understandably wary of using a drug just for Black people. One elderly Black woman stood up in a community meeting and shouted, "Give me what the white people are taking!" And if you find race-specific medicine surprising, wait till you learn that many doctors in the United States still use an updated version of a diagnostic tool that was developed by a physician during the slavery era, a diagnostic tool that is tightly linked to justifications for slavery. Dr. Samuel Cartwright graduated from the University of Pennsylvania Medical School. He promoted the racial concept of disease, that people of different races suffer from different diseases and experience common diseases differently. He claimed that because Black people have lower lung capacity than whites, forced labor was good for them. To support this theory, Cartwright helped to perfect a medical device for measuring breathing called the spirometer to show the presumed deficiency in Black people's lungs. Today, doctors still uphold Cartwright's claim that Black people as a race have lower lung capacity than white people. Some even use a modern-day spirometer that actually has a button labeled race, so the machine adjusts the measurement for each patient according to his or her race. It's a well-known function called correcting for race. The problem with race medicine extends far beyond misdiagnosing patients. Its focus on innate racial differences in disease diverts attention and resources from the social determinants that cause appalling racial gaps in health: lack of access to high-quality medical care, food deserts in poor neighborhoods, exposure to environmental toxins, high rates of incarceration, and experiencing the stress of racial discrimination. You see, race is not a biological category that naturally produces these health disparities because of genetic difference. Race is a social category that has staggering biological consequences, but because of the impact of social inequality on people's health. Yet race medicine pretends the answer to these gaps in health can be found in a race-specific pill. It's much easier and more lucrative to market a technological fix for these gaps in health than to deal with the structural inequities that produce them. The way doctors practice medicine continues to promote a false and toxic view of humanity. Despite the many visionary breakthroughs in medicine we've been learning about, there's a failure of imagination when it comes to race. What would happen if doctors stopped treating patients by race? What if doctors joined the forefront of a movement to end the structural inequities caused by racism, not by genetic difference?